Thank you, Dr. Haribhakti and Kaizen team for inviting me not in the panel discussions, but for a 15-minute presentation on geometry of MIPH or stapler hemorrhoidectomy. I hope all of us know what is the meaning of Kaizen. Anyone? Except for Dr. Haribhakti, anyone? Kaizen is continuous improvement, and this is the word which has always impressed me, and that is the reason that I am at Ahmedabad many times. On just fall of the hat, I always wish that we should be unlearning, learning and relearning and carry on learning. And I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital. Now, we know that stapler hemorrhoidectomy is a simple procedure, but definitely it can have lot of challenges. And whenever all those fellows come to us, whether from GI surgery or from any branch, we always ask, what are the 9 synonyms of stapler hemorrhoidectomy? And we feel that hemorrhoidectomy is a wrong connotation. It should be stapled hemorrhoidopexy or stapled enopexy, and most of the operation can be summed up in just 2 words, and that is circumferential mucosectomy or prolapsing mucosectomy. What I mean to say, in this procedure, what we do is that we have to take the mucosa out, and it is not the hemorrhoids that we have to take out, it is the proximal mucosa that has to be taken out, so that the drooping anal cushions, they go back, and ultimately we are able to fix, and that is why it is also called as anal facelift. Now, why we are discussing this such a topic? I know that most of you would be very comfortable with MIPH, but again we say that the width of the donut has to be 3.5 centimeters. Many times, if you ask me one step in stapler hemorrhoidectomy which is most important, and that is taking the pulse string suture. So if we are taking the pulse string suture so nicely that ultimately we are not leaving the mucosa in between, we are taking 2 bites in each quadrant, and then it is a circumferential, maybe starting from 3 o'clock and coming back to 3 o'clock, or applying another one at 9 o'clock and then putting the traction onto the mucosa, so that ultimate aim is that we should have a donut which is not having muscle layers, which is only the mucosa and submucosa, and which has a width of 3.5 centimeter. Many times, many of the complications we have seen, and believe me, I have never ever thought that stapler hemorrhoidectomy is a simple procedure. It is not, because the complications of the order of, I had gone to one of the workshops, doing workshops in Srinagar, and I was given 9 cases to be operated for stapler hemorrhoidectomy, and I was told by the organizers that they have organized 4 units of blood for every patient, and do you need more? So I said that I need for myself. Why the blood has been arranged for 4 units per patient? Are any and every patient is anemic? They said no. Last time we had called one faculty and so much of bleeding was there, so the patient needed 4 units. So that is the reason that all 9 patients have been arranged and 4 units of blood have been arranged. Our thinking is we do not need blood. We only thing is it is a absolutely technique driven procedure. Again, if you are taking the muscles along with, you can cause incontinence, or if you are taking the smooth muscle, then you can cause stenosis, and recurrence is of the order of 3%. Stricture can occur, and especially urinary retention is a known phenomenon with this, so one has to be very sure. And especially in female patients, it is a good thought once we close the stapler, please do the pervaginal examination so that we are sure that we are not going to cause the perforation and we are not going to cause the rectovaginal fistula. And as we know that dentate line is very, can we have the pointer? Dentate line is very important. Above of dentate line, we have the internal hemorrhoids, and internal hemorrhoids, it has the columnar lining and it has the viscerally innervated, and therefore it is painless. That is very important, that above the dentate line it is painless, and below the dentate line, that means external hemorrhoids are there, and this is because the somatic innervation is there, and that is why the pain is there. So one has to be very careful. We do not offer stapler hemorrhoidectomy for grade 1 and grade 2, but for grade 3, yes. And grade 4, sometimes you have to think whether you will be able to perform the stapler hemorrhoidectomy or not, if you are able to reduce it on the table or not. Again, the procedures can be divided into whether they are non-excisional procedures or excisional procedures. Means, if for example you are just doing the ligation or tissue destruction, or you are fixing, that is hemorrhoidopexy, or you are excising, that is a hemorrhoidectomy. I am not talking about Morgan-Milligan operation, but you can see that the history has shown us from more invasive to less invasive. The tissue excision was described by Whitehead in 1882, then Cushion's excision, and then mucosal excision above dentate line, and after that by Moringa, no excision, that is the transanal hemorrhoidal dearterization. So our thinking is again and again, we should be knowing that it is sin. I am using very strong word. It is sin to do the stapling below the level of dentate line. Patient will have lot of pain, and one should know the geometry in the sense, from the anal verge, dentate line is of the order of 2 centimeters, and this anorectal ring, the cushions, have again 1.5 to 2 centimeters. That means our pursing suture has to be above that level, and if that has to be above that level, then only we will be in a pain-free zone, otherwise we will be in the painful zone. And when we are taking the pursing, please make sure, and it becomes a habit, nobody can teach you, please make sure that you are using the fiber optic light, the laparoscopic light which you use, the cable, so that we are able to see within, and with the help of a long forceps we just lift up the mucosa and submucosa. We do not include the muscles in it. I know that people have caused perforations of the rectum, people have caused lot of bleeding on the table also. So one has to be very careful that we do not leave the mucosa behind. We do not take the muscle along with, we go into the muscle, into the mucosa and submucosa, and then take this small clip. This describes that this was the hemorrhoid, it had come down, the cushions had come down, and now our aim is that we should be 2 centimeters away, that means 4 centimeters from the anal verge, and further 2 centimeters up, so that we are able to take this mucosa out. And it has to be having a width of 3.5 centimeter. That means we should know where exactly one has to apply the pursing suture. Many times, initially when it was described by Longo in 1998, many people started doing this, but they had to cut a sorry figure. Why? Because they were just below that level. In this small photograph, I have tried my best to give the geometry in the sense, as we know that this is a transparent circular anoscope, and this is a PSA, pursing suture passer anoscope, and this from anal verge to the margin of this is 3 centimeters, and this is called as shelving portion of the PSA. This portion is having a fold like this, so this is called a shelving portion. So we have to make sure that we are going with the pursing in between the shelving portion and the margin of the transparent endoscope, so that ultimately we are not very close to the dentate line when the mucosa comes, or we are not very far off so that no mucosa comes. So ultimate aim is, and then when we take the sutures, especially for my younger colleagues, I would advocate that please use the needles that is a double arm suture which is provided with MIPH gun, and it has a dimension of 26 millimeter half circle. What I mean to say that if you take a bigger needle, then also you will not be able to do it. If you take a smaller needle, then also it becomes challenging to go into the mucosa and submucosa. And when we are firing, we are in a habit of using PPH 03, and 03 would mean that 33 millimeter is the diameter, and when the clips, the staples close back, then it is 0.75. So one should be very, very careful when we are firing, because PPH 1 used to have 1.2 millimeter when the limb length was closed, and that would lead on to more bleeding at that end. So one has to be very, very sure that we place in and we just dissect this 3.5 centimeter donut, so that ultimately as soon as we apply the staples, the cushions go up, the mucosa goes up, and that is why it is called as mucosal prolapsectomy or collapsing mucosectomy, and then stapling, and then it causes the anal lift. And again, this is very, very important that we should know by millimeter. I think that is very, very small message, but very important message which I want to convey in this presentation is that please respect the millimeters so that you are not causing any challenge. And now, as I mentioned, these are the small steps which we use. For example, fiber optic cable, the forward oblique position of the needle, and PV should be done before and after, and pursing has to be applied. There are surgeons who would start the pursing application at 3 o'clock and finish off at 3 o'clock and then pull. But there will be many surgeons who will be applying at 3 o'clock as well as 9 o'clock, so that it becomes a good pursing. Our thoughts are that mucosa has to be in such a manner that ultimately the 3.5 centimeter dimension is definitely come out. There are patients who, for example, will be obese, morbidly obese, and if you are doing this, then this endoscope may not go in properly. So one has to trim this portion so that ultimately it is fitting very nicely into the anal opening, and then you are able to do it. And again, if we are taking a long needle driver, definitely it helps. And if you are taking a curved needle driver, it definitely helps. And if you are making the needle forward oblique in this manner, so that when we are taking the suture, we are in the same plane again and again. Same plane, so much of distance from the anal opening, so that ultimately we are not causing. Now you can see the fiber optic cable, one becomes very, very comfortable. Once we have done the stapler hemorrhoidectomy, then we always place this Malicot grain, and it has been packed with the gauze piece or wound all around, and with Fairly or Sofra-Tulle and lignocaine jelly has been applied. In this small video clipping, I am just showing, if you are using the pursing suture at one place, that means maybe at 3 o'clock or 9 o'clock, that becomes a pursing, but it may be ununiform kind of pursing. But if, for example, if you are using the pursing of this sort, that means the two sutures have been applied, and then you are tightening and tightening, so that ultimately it is a regular pursing. So again and again, aim is that we should not have the donut which has a very small width at one side and a large width at the other side. It has to be a uniform width, so that ultimately we are able to do it. Now in this small video clipping, you can see the movements. We should never ever work on the shoulders. It should be only the wrist joint that we are working. We are taking the pursing suture, and as we take the pursing all around, then we will place in the gun. And again, the gun has to be placed after doing the per-rectal examination with PSA inside. Many times, if for example, if the gun is pointing anteriorly, or if the gun is pointing posteriorly, then also one can cause damage to the rectal wall. So one has to be very, very careful when we are putting the anvil as well as the shaft. And as we put in the anvil, there has to be a give way sensation. Means as soon as you go in, then we should make sure that anvil goes in, and then we apply the pulsing suture tightly, and then with the help of pulsing suture passer endoscope, we take the suture, and continuous traction is maintained so that the mucosa goes into the housing of the stapler. This is very, very important, that it should go into the housing. And when we are closing the mucosa, when we are closing the housing, then also please make sure that we wait for 30 seconds, and then we should hear the voice of clutch. Otherwise, I know there are staplers, there have been misfires also, that once we press on the clutch and the staples are not there. So this kind of situations can occur. So one has to be very, very careful that we do not cause these kind of challenges. And again, as we go in with the stapler gun, please make sure that when half of the staple gun has gone in, then also check it, that whether the movement is free or not. And once the movement is free, then only go in, wait for 30 seconds, and then fire the stapler. After this, one should always check, recheck, cross check, counter check, check. If for example, I would say many times, if you have waited, if your pulsing is nice, many times you may not need any sutures over the staple line. You may not, you will not. But I have seen surgeons using the cautery, monopolar cautery on the staple lines. That should never ever be done, because that can lead on to fistula formation. And again, check the donut, always check the donut, always check the width, always check whether the muscles have been taken in or not, and then only one will be able to do the justice on that. And in this, now you see that is playing. I am ready to take any queries, any questions from any of you, so that ultimately we become wiser and we do not cause any challenge in this situation. Any questions, please? All of you are so comfortable with the stapler hemorrhoidectomy, then no questions? Good, excellent.
If the external hemorrhoids are large, like if you want to remove the external hemorrhoids, so previously you have shown that this animated part, that once we do the hemorrhoidectomy or hemorrhoidectomy, then it will go up, right? So whether we have to remove the external abdominal portion or we have to leave it?
Very good question. No, our intention is that when we are putting in the obturator, then the external hemorrhoids have to go in. One should not hold with the artery forceps or the caries and take them out. No, they have to go in, and once your transparent endoscope is comfortably placed, then place the suture. If for example, if you start excising those external grade 4 hemorrhoids, then again, as I mentioned, this will be below the level of dentate line, and that will be challenging, that will be painful. So we always tell the patient, especially as I put it in a bracket, if it is a grade 4, always discuss with the patient pre-operatively, because it has been a long-standing hemorrhoids, it has been a grade 4 hemorrhoid. So these masses will not vanish off immediately. It will take around 4 to 6 weeks to shrink in size and ultimately reduce in size. But many times, and most of the times, we will not have to go in again to excise these grade 4 tags.
Yes, sir. But in practical scenario, like we have seen that this external portion of the hemorrhoid is get elevated or congested in the post-operative period, which is painful.
Sure.
So the idea of surgery is like patient doesn't know pain, but this external hemorrhoid due to congestion, it becomes painful, and we have to wait, as you mentioned, it's 4 to 6 weeks. It will be long for patients. Sometimes patients feel like it's like a stricture, and we have also operated in the mind because we read about the complications of stapler hemorrhoidectomy. So we thought it's a strictured area. So how we can manage any medication or anything
Yeah, medication, basic medication is time. Carry on telling the patient that it will take 3 weeks. After the 3 weeks, again there will be masses. It will definitely carry on shrinking. Another 3 weeks, and most of the times in 6 to 8 weeks they shrink. And many times, I would say most of the times, we do not have to excise those external masses. But it is a good idea, and you have rightly pointed out, it is a good idea to discuss this patient about this condition pre-operatively rather than post-operatively. Because if they are grade 4 hemorrhoids, and if you have gone in for MIPH, patient may have lot of complaints after that, that you have left the masses, you have not done the operation nightly, and then he will go to another surgeon who will never do the stapler hemorrhoidectomy, but he would always do the Morgan Milligan, and he would also incite, no, wrong surgery has been done. So our thinking is that please, yes sir, Dr. Ardol.
Have you ever done the failure of the stapler? If so, how you have managed?
Yeah, excellent. I have never ever had this occasion because frankly I am married to one. Married to one means I am married to Ethicon Johnson Johnson, and I have been using it. I know that there are surgeons who have been using the Chinese stapler. There are surgeons who are using A, B, C staplers, and they have had the occasion that they fired and there were no staples inside. There was no glitch or glitch in when they were pressing it, and there were no staples. And would you be surprised that both the rectal mucosa, everything has been washed off, and now there is a lot of bleeding. So our thinking, and I have heard and I have seen, we were discussing, Dr. Kullar and myself were also discussing last week, that there are situations when new kind of staplers come and they do not fire or misfire. So I have not changed my stapler to, if somebody gives me some Chinese stapler, I don't do it. I would never ever do it, even in workshops, because ultimately we are answerable for that. So misfire are known, and one has to be very, very cautious about these. And one can always have the comparison between open versus MIPH, and definitely the pain scores, as we have discussed, the pain scores are definitely less in MIPH as compared to conventional, and again the follow-up is good. So one should be afraid of the complications. One should know the bleeding can occur, and I know there have been situations in which the perforation have occurred, then gone in for colostomy or ileostomy, and then the sepsis was also there, and ultimately the patient had cascade of events after this simple procedure. So please do not think that stapler hemorrhoidectomy is a simple procedure. Definitely one should know, and then again one should know that one can cause rectovaginal fistula. We have seen one done outside, and one could see, but just because when we are closing the anvil and the shaft, one should always do the per vaginal examination so that we do not miss or we do not take the vagina into it and cause a different challenge. And we always tell our patients right from word go, train not to strain, train not to strain. Ultimately, when the patient comes, we all should always try to tell them that it is the constipation which was responsible, and constipation we have not done anything for that. And you have to make sure that you change your lifestyle, you change your habits in such a manner that you do not do, when you are sitting on a toilet seat, please finish off the WhatsApp messages before or after, but not on the seat, so that ultimately you are not overstraining on the commode seat and then causing challenges later on. Thank you very much. Thanks a lot for your kind attention. Thank you, Dr. Haribhakti, for this kind of opportunity. Any other questions?